But welcome to today's webinar, Providing a Gender-Responsive Approach Throughout the Continuum of Care. I'm Dr. Marianne Roy, and I'm the Chief Clinical Officer at Crossroads. Crossroads is a Maine-based organization, and we specialize in behavioral health and addiction services. We have 2 outpatient locations here in Maine, and we also have 3 residential programs specifically for adult women that are experiencing challenges with substance use disorders. And we also have a residential program for adult women that are experiencing challenges with co-occurring substance use disorders and eating disorders. So today's webinar is primarily focusing on a woman's experience throughout the continuum of care. I'm hoping that today, after participating in this webinar, that all of you will be able to explain the unique needs of women in substance use treatment and be able to have some takeaways to apply in your own work settings, some clinical interventions that really work well with the adult woman population, as well as understand and discuss trauma-informed approaches that support gender-responsive treatment for women. So when we think about addiction, substance use disorders, it's not uncommon for us to begin thinking about the shame, the stigma, and the guilt that is paired with substance use disorders. When we think about women in our culture that are experiencing challenges with substance use, and and some of these women are mothers, are pregnant, are parenting, sometimes you got to really think about how the shame, the stigma, and the guilt is often magnified in that population. Oftentimes in our culture, when we think about substance use disorders and the stereotypes that go with that, we're not oftentimes thinking about, a mother who might be using, a mother who is pregnant and parenting. And oftentimes this is a population that will not seek treatment because of the shame and stigma associated with being a mom. And oftentimes they have concerns about where they're gonna, who's gonna support their children while they do seek treatment. So this is a really important topic today. And again, I thank all of you for joining. I also just want to let people know that I will be accepting questions at the end of the webinar. I'll be sure to leave some time at the end to answer any questions that you may have, so feel free to type in your questions, and towards the end I will get to those. Little exercise that I like to do sometimes here at Crossroads with my treatment teams, or when I'm presenting this topic live with a live audience, is to present a case that's typical of a female that might be seeking out our services. And I'll read through a history and just some basic phrases that women have shared with us. And then I ask the audience to think about, what are the emerging themes that you see when I present this case? What are the risk factors that are present? And the audience will then share many of what you're seeing on this slide that I'm showing right now. I'm not going to go through I'm not going to go through word for word what I would present in a live training, but I'll give you some excerpts. Picture a woman who might be pregnant. Prior to finding out that she was pregnant, she may have been using, could be a woman in recovery who had had a relapse, the extreme guilt that then comes because she's pregnant and had been engaging in maybe some alcohol use, maybe protective of her family. Her husband may be in recovery as well, trying to keep the home life together, support the husband's recovery, but feeling immense guilt. Husband finds out that she's pregnant, doesn't believe that she's pregnant, wants to double check the test to make sure that she is. And then the mom feeling even more intense guilt because maybe the partner doesn't support the pregnancy. So not only the guilt of the partner possibly not supporting the pregnancy, but also wanting to make sure that she has a baby that's healthy. And she herself wants to be a responsible mom. So mom enters treatment, but enters treatment with a lot of shame and questions, what kind of mother am I? I feel like I'm a bad person. Returns home and has the pressures at home haven't changed. The need to maybe support the husband in his career, older children that may be at home, still has to complete the duration of her pregnancy. People in her life knowing that she had relapsed, even though the family members may understand that addiction is a disease, it doesn't necessarily take away from the fact that certain pressures, the mom's experiencing certain pressures in regard to being the caretaker and caring for the family, and just feeling incredibly overwhelmed in all aspects of her life, and developing this narrative of I'm a bad mom, and really reciting that to herself over and over. These are not uncommon stories that we hear at Crossroads, and I'm sure what I'm sharing with you, if you're someone who works with moms and women, this may not be an uncommon scenario either. So I encourage you and your teams and in your maybe group supervisions with other clinicians to discuss these cases from that lens of what does it look like to be a female in our society? What does it look like to be a mom who's experiencing challenges with substance use disorder, and see what risk factors and emerging themes present themselves. And then what I like to do is then present this next slide, which is some information from Stephanie Covington around the common themes for women with substance use disorders. And you can see that there are many. What was on the previous slide is absolutely reflected in this. The shame, the stigma, the potential history of abuse, relationship issues, fear of losing a partner or needing partner's permission for treatment, you know, and then the systemic issues, if there's lack of financial resources for treatment, lack of clean or sober housing, poorly coordinated services. You can see that these are very much present in the lives of women. Here's a quote from Women Under the Influence. As girls grow and develop, the transitions into adolescence and early adulthood, entering middle school or junior high, entering and graduating from high school or college, or entering the workforce, frequently involve many changes in the social and physical environment that influence their risk for unhealthy behavior. Some aspects of these transitions appear to affect girls and young women differently than boys and young men, as they form attitudes, beliefs, and habits that can influence their use of cigarettes, alcohol, and drugs. And I include this quote in the webinar and in the training because I think it really emphasizes the importance of what gender responsive treatment is. And oftentimes I hear people say, yes, we provide gender responsive services. And when I say, tell me a little bit about that, what they might say is, well, we have group programming for women and we have group programming for men, but then the clinical interventions are the same in each setting. So that tells me that there's some gender separation taking place, but yet the responsiveness might be missing, because the responsiveness comes from what are your treatment approaches that are geared specifically for the female population. So gender shapes context. Research suggests that social and environmental factors, including gender socialization, gender roles, gender inequality, contribute to behavioral differences between men and women. And it's important for us in our work with our women to be able to talk about what does it mean to be a female in this society? What are the messages that we get from our culture, from our family, the expectations that may be placed on us by virtue of being a woman? And it's really important that women understand that they're not alone in feeling like they need to be the caretakers, the nurturers, that they need to do everything. What does it mean to be a female in a male-based society? And it's important to ask, what does it mean to be a man in a male-based society? Reflect on the meaning that what it means, we must reflect on the meaning we attach to what it means to be female and what it means to be male, and what it means in terms of what have your experiences been in your life by virtue of your gender that have shaped some of the experiences that you've encountered. And we see this play out a little bit with trauma, which I'll get into further on in the presentation, because the experiences that men and women have differ throughout the lifespan, and it's important that we acknowledge what those differences are, because that's where recovery can sometimes look a little different. So there are unique physiological and psychological differences between men and women in regard to the onset and the progression of addiction. And these are important topics to really talk about when you are treating a client either in your outpatient practice in an IOP or residential level of care. It's really important for women to understand how their biological, psychological, physiological systems are different from their male counterparts. Women typically become intoxicated faster after consuming smaller amounts of alcohol than men, and this has to do with higher alcohol concentrations, more body fat, and lower volume of body water to dilute the alcohol compared to men. I think this is really important to talk about because oftentimes what we have heard our women share with us when they enter treatment is that they were with a partner, maybe they didn't have any experiences or challenges with substance use disorder prior to, and was with a partner who was struggling with substances. And connection is incredibly important in the lives of women. Relationships are incredibly important in the lives of women. And all of a sudden, this woman starts going drink for drink with her partner. And she's starting to experience the health-related challenges much sooner than her male counterpart. So it's important for women to understand their bodies and to be able to talk about their bodies. This is why if you are able to incorporate medical or nursing into any of your programs to maybe talk about these issues and run a specific group, that's incredibly helpful. So in regard to alcohol consumption, women are at greater risk for developing liver damage, brain damage, and heart disease. Women who smoke cigarettes are at increased risk for long-term health consequences, such as lung cancer and heart problems compared to men. Here are just a few more statistics for you that you can review, and you will have access to these slides as well, because I believe C4 will be sharing these with you. Women are more likely to have chronic pain, be prescribed prescription painkillers, and be given higher doses and use them for longer periods of time than men. This isn't uncommon. We oftentimes see women enter into our residential programming with a significant list of medications. And oftentimes they don't even understand why they're taking the medication that they're taking. And that's always very concerning. Sometimes the person that's prescribing isn't aware of the substance use disorder that their patient is presenting with. So for us, it's really important as providers to get a release sign and contact and begin collaborating with other treatment providers, especially prescribers. We have seen women prescribe benzodiazepines, for example, for very long periods of time to treat symptoms of menopause that they may have gone on in their late 40s, and now here they are, late 50s, early 60s, and they have this dependency on this substance, and there are some other substances of misuse occurring at the same time. So presentations can be complicated, and it's really important to review a client's and a woman's prescription list with them and see if they understand why they're taking what they're taking, and then for us to do our due diligence as providers to collaborate with prescribers. Studies show that women who inject drugs engage in more HIV risk behaviors and may have higher mortality rates than men. Once infected with HIV, women progress to AIDS more quickly than men, and women are more often than men to have a sexual partner who injects drugs. Studies have also demonstrated that women share injecting equipment with more people in their social network than men. And I think that this last bullet is really important to look at, especially from a cultural lens. And when providing gender-responsive treatment services, it's really important to also look at the culture that a woman is living in or is from, because there are some cultures where a woman will be the last to use any injecting equipment, and everybody else will go prior to her. So you can see how that sets her up for even increased risk. So gender-responsive, women-centered services are the creation of an environment through site selection, staff selection, program development, and program content, material that reflects an understanding of the realities of women's and girls' lives, and that address and respond to their challenges and strengths. And this is directly from Stephanie Covington. I encourage everyone to look and become familiar with Stephanie Covington's work. She is phenomenal in the area of gender-responsive treatment for women. And take a look at your settings. Are they set up in a location where women feel comfortable accessing treatment from you? I say that because these are some things that we at Crossroads pay a lot of attention to and put a lot of focus and attention on. For example, we used to have a location that, fabulous location, but the parking was not conducive to our clients coming to our office after hours or in the evening. Women would have had to access maybe a parking garage or walk a few blocks down to get to our services. So not only did it feel comfortable for our staff to access us in the evening, for our clients to access us in the evening, you're also kind of setting your staff up for some discomfort there as well. So we made a choice as an organization to move one of our outpatient practices to a location that the parking was right on site, the parking lot was well lit, to really increase accessibility for women who are seeking our services after hours. In addition, take a look at your actual office space. Is it warm? Is it inviting? Pay special attention to your front desk area, your admissions department, who are your clients seeing when they first walk through the door? What are the messages? Is the message that you're sending your clients that this is the place that is safe, secure, you can come here and start doing the work? Because that's what you want. To have a site that may have that may appear disheveled, where the space may seem chaotic, it can sometimes start increasing the anxiety of the women that we serve. And so I encourage you to take a look at your physical space. I included in this presentation the principles of gender responsive services from SAMHSA, the Substance Abuse Mental Health Services Administration. I'm not going to go and read through each of these because some of you may be familiar. For those of you who are not, again, you'll have access to these slides and can review these in more depth. But it's really important to take into account these principles when serving our female population. So for example, socioeconomic status is incredibly important, and we should be examining that through the lens of employment, educational status, people's transportation, housing, literacy levels, and income. Cultural competency, I alluded to just briefly, but where are women coming from? What is their cultural background? What's their family like? What is their family of origin like? And how has their cultural background how's it influencing them? Because it's certainly going to maybe influence some of the recommendations that you make in treatment. And also sometimes what we see, women will come to us and may not want to incorporate family work into treatment because this is something that within their culture is very much shunned upon. So we need to be very cognizant of how do we help women connect to sober resources and sober supports? How do we help them start navigating that and then work with whoever the aftercare provider may be, depending on how long the client is in treatment with us, that can begin maybe doing some of that deeper level work with the family. Relationships are incredibly important in the lives of women. At Crossroads, we utilize the relational model. It's really important when our women walk through our door that we offer a corrective experience for them. We need to acknowledge the significance of relationships in the lives of women, and women are striving for connection, and oftentimes with our substance use, with our clients experiencing challenges with substance use disorder, they may be experiencing relationships where they aren't particularly safe. And sometimes that safety will get compromised in order to strive for that and achieve that connection that women are looking for. So it's really important that we offer a space and relationships that are healthy and corrective to begin giving them that experience of what they can look for in a relationship when they leave treatment. Health is incredibly important. I alluded to that a little bit ago when we were talking about just the biological differences between men and women and the health-related risks associated with substance use, and the importance of having nurse and medical providers that could perhaps facilitate some groups. Developmental perspective is incredibly important as well. One of the things that we need to consider when we're talking about women with substance use disorders is that, oftentimes one of the things that Stephanie Covington emphasizes is that where there's addiction, there's oftentimes trauma. And where trauma has occurred and at what point trauma has occurred in a woman's life and at what point the substance use may have started to take place. We need to really spend some time looking at that time period, because that can definitely impact a woman's psychological development and where they are. And it can also impact a cognitive development. So we need to take these factors into consideration and be mindful as providers that some of our clients may require more patience and more verbal cueing and more support with direction of their recovery. Caregiver roles. This is incredibly important in the lives of women. Women will not enter treatment most often if they do not have someone that they feel that they can leave their children with that's safe. In addition, women also have this belief that they are the ones that are running their household, taking care of things in their household. We see sometimes challenges, especially, with women that are entering into our residential program and partners that then call who are now recognizing, oh my goodness, when she is not present, I can't manage my own medication, or I can't manage my children's schedules. And so you sometimes experience family members, partners getting on the phone with the client, and then they start venting about how it's so difficult at home and how they, just can't do their medications because, so-and-so has always done this, you've always done this for me. And then the next thing you know, you might have someone who's leaving treatment against clinical advice because that caretaking role is so strong. So again, that early intervention with the family is incredibly important. Looking at gender roles in the lives of women as well, and how this has been just reinforced in their own life and within their own family, and what are the stories that they've come to be told. This is a wonderful group to do with women, because you'll get some very interesting common themes that arise, and for women to feel this sense of connection of, wow, I'm not the only one that's sitting with this. This hasn't been my unique experience. This is actually a shared experience that I have with other women in the room. And then you can also start building in the recovery around how to cope with how they manage what those maybe unrealistic expectations have been that either others have put on them or maybe they have been putting on themselves. And treatment also needs to be trauma-informed and trauma-responsive. You'll hear me reference Stephanie Covington quite a bit. It's really, it's almost impossible to do addiction treatment without acknowledging the role of trauma in the lives of women. If you are operating a program, residential program, IOP program, if you're doing outpatient work, if there's a woman that you are working with that's presenting with a substance use disorder, it is really important to do a thorough assessment on any past or current trauma, because if trauma isn't treated, if it isn't addressed and talked about, what you're going to see are higher rates of relapse. So essentially, you can do all the relapse prevention planning that you want, but oftentimes, triggers for a relapse are oftentimes centered in trauma. Keeping programming strength-based and multidisciplinary is incredibly important, and being consistent and generalizable and competent. So making sure that if, at Crossroads, where we have 3 residential programs and 2 outpatient locations, it's really important here that our supervisions are gender responsive, that our clinical team meetings also reflect that gender responsive lens, and that we're constantly looking at things through the lens of gender, the experience of trauma, and incorporating all of these principles that I've reviewed. So what it means to be trauma informed is really, it's almost impossible to do this presentation without talking about the importance of being trauma informed and trauma responsive. So being trauma informed can be applied, trauma informed care can be applied in any setting, and is an approach that increases sensitivity to the past or present experience of trauma. It's separate from trauma-specific interventions and treatments that are designed to specifically address the consequences of trauma and promote healing. So according to SAMHSA, a trauma-informed approach realizes the impact of trauma and understands paths for recovery, recognizes the signs and symptoms of trauma in clients, families, staff, and others involved in the system. And I think that's really an important one to emphasize. You know, not only do our clients oftentimes have a history of trauma, there have been significant strains and maybe some intergenerational trauma that's existed within the family system. Certainly our staff, you know, who do a lot of heavy lifting, you know, the interplay of trauma is always incredibly important to be looking at and be mindful of. This approach responds by integrating knowledge about trauma into policies, procedures, and practices. And of course, our goal is to avoid re-traumatization in any type of treatment setting where we're treating all clients. So SAMHSA's 6 key principles of a trauma-informed approach are safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, cultural, historical, and gender issues. So safety, making sure that our sites are welcoming, that they're secure. It's incredibly important that we're not judgmental. Sometimes our clients will engage in treatment and experience a period of recovery, may exit treatment for a period of time, and then they may come back. And I always think it's great when our clients can come back and they know that they can walk through our doors again, because that tells me that we're doing something right, that our clients are not feeling, I'm sure there's shame and there's stigma and it's difficult to walk through those doors again, but to be able to come back in and begin doing the heavy lifting again, that tells me that we're doing something right in terms of offering an environment that's non-judgmental. Tone of voice, body language is incredibly important. We need to make sure that we're speaking with our clients in respectful tones of voice, that our body language isn't threatening in any way. And I think it's just important for all of us to look at our own automatic behaviors. And it's great to get the feedback from peers, coworkers, supervisors around our performers to make sure that we are welcoming our clients. It's also good to look at, you know, sometimes when reflecting on no-show rates of our clients that may come but then not return for treatment, these are good principles to just go back and review and make sure that you're consistent and that you're looking at your own practices and are they consistent with these principles. So location is incredibly important. I spoke a little bit about how we actually moved our site at one point in time. Trustworthiness and transparency, especially in the lives of women who may have experienced a history of trauma and they've been told, you know, one thing and, you know, and then something else happens. It's really important that we're very honest and we're very transparent when it comes to the care of our clients. Releases are signed. We're transparent about the expectations of treatment and consultation, the importance of collaboration with other treatment providers and support of others. Sometimes clients, you know, are not on board right away with supporting a conversation between their clinician and their primary care that may be prescribing certain medication, or really helping to educate the client on why that's important, how we can together be a team in the recovery. And it might take a little bit to get there, but continuing to collaborate with the client is incredibly important. And it also reflects a non-judgmental approach and a relationship that's not authoritarian. Predictability is always incredibly important, especially with trustworthiness and transparency. You know, what I always emphasize here at Crossroads is that it's really important for sessions to start on time and end on time, groups to start on time and end on time. And what you say as a provider, as a clinician, as a facilitator matches your actions. Consistent scheduling is incredibly important. We want to avoid frequent changes in the schedule and really acknowledge, you know, it isn't always easy for our clients to get here. Some have transportation issues. Some are balancing work schedules with children. So in order to, you know, say that we're going to meet with a client at a certain time and to be there is such a gift to the population that we serve. I think it's also important to talk about in terms of predictability, you know, having the expectation too that your client arrived to group on time or arrived to session on time can because sometimes I'm sure we've seen clients and have had the experience of clients arriving late. And then what can happen sometimes if that isn't a clinical discussion that's brought into the session, the clinician can sometimes begin experiencing feelings of resentment. And so that's why supervision is incredibly important. It's really important for us to process with our clients. Gosh, I noticed that, the past couple of sessions, you've arrived 15 minutes late. What's that about? What we might find is that this could be a reflection, maybe, yes, of maybe poor time management, which you can certainly support them with that, but sometimes it's also a reflection of a very low self-esteem. I've had clients tell me before, well, I didn't think the group would miss me if I was late. I didn't think that you would care if I showed up 20 minutes late to session. So this feeling of going through life as though other people don't care is very important to explore with our women. And then hopefully as providers offer a corrective experience. Peer support, incredibly important. Connections with the 12-step community, recovery coaches. We try to offer our friends and family series every once in a while here at Crossroads, which is free to the community, to provide some education to affected others around substance use disorder. And, if you are able to have an active alumni association or remain in contact with alumni, they can be wonderful as well in helping with continued support around sobriety with current clients and programming. Collaboration, mutuality, incredibly important. We're walking this journey with our clients, and, we do not want to we don't want to exert power or control over. The relational model of treatment is incredibly important, and that's really treatment that builds upon and respects people's unique needs to focus on self-determination, personal choices, positive relationships, and connectedness. And then empowerment, voice, and choice, incredibly important in the lives of women, especially women that haven't found their voice, don't know how to use their voice. Sometimes some difficult decisions need to be made. Sometimes calls need to be made to DHS. Being able to do some of that with the client present. If it's a client who may be prescribed a medication that they're misusing that's being prescribed, making those phone calls with the client present in session to whomever the provider is. So that way you can talk about, yes, this is happening, but here's how we're going to support this person in treatment. And cultural, historical, and gender issues. So, comprehensive assessments should ask specific questions pertaining to these three things. Does the client require any special accommodations to receive services or participate in services? And really taking a close look at how the programs support cultural and historic and gender issues on a case-by-case basis, because sometimes this could look unique from individual to an individual. So I love this quote by Brene Brown: when we deny the story, it defines us. When we own the story, we can write a brave new ending. And I think that sums up the importance of talking and incorporating curriculums that center around trauma into programming, because what you are now able to start doing is really bringing a voice to something that may have been repressed for quite a while. So at the residential level of care, the focus is on stabilization and sometimes crisis stabilization. This is when women enter treatment at the very earliest stages of their recovery. They may be coming from a hospital, a crisis stabilization unit. They may be coming from a DV shelter or have left a DV situation. Or they may be elevating up. Maybe an IOP level of care, intensive outpatient programming, wasn't enough to help them maintain their sobriety, and they need a higher level of care for support. So women at this stage may or may not be withdrawing from substances. They may or may not be adjusting to psychotropic medication, but they are very much stabilizing and really settling into some very intensive treatment. So the decision to enter residential treatment is often the first action towards disrupting the guilt and shame cycle. I spoke earlier about how lack of childcare is sometimes one of the strongest barriers for women to enter a residential level of care. You know, our moms, especially that are entering treatment, are experiencing intense amount of guilt and shame for, you know, what their children may have experienced during their active use. Shame is explored through processing experiences and receiving empathy and compassion from staff and peers, and the process of realizing I'm not the only one. That's incredibly healing. I think oftentimes when you go and you walk into a residential setting, or if you're someone who's providing a group specifically for women in your outpatient setting, when they begin to realize I felt like I was the only one in this pressure that I was putting on myself, and now I understand that this is a shared experience and I'm not unique in this, and that there is hope, because in a residential setting, oftentimes admission to the program is rolling, so you have people at different phases of their recovery, and sometimes women with a little bit more recovery under their belt that have been in the program a little bit longer are really able to offer a lot of strength and hope for current clients. Relapse prevention is a focus of treatment, along with trigger identification and learning to recognize and challenge addictive thoughts. And this is where I can't emphasize enough the importance of incorporating a curriculum that's centered around healing from trauma and how to begin healing from trauma. You know, here at Crossroads, we like to use healing trauma, beyond trauma. These are wonderful curriculums to support women in treatment with us for substance use disorder. Residential treatment is oftentimes a safe environment for women to begin their healing process. We certainly strive for safety in our environments and look at things on a frequent, consistent basis to make sure that our clients are in an environment where they feel like they can begin healing. And learning to establish boundaries with staff and peers. That I can't emphasize enough. You know, we talk about the automatic behaviors. You know, people just can't turn off their behaviors. So really helping clients to begin to develop insight into their actions. And for women especially, sometimes there's this illusion, I feel like Claudia Black said this best, where, you know, premature sharing doesn't mean intimacy. So really helping women understand that there are things that can be shared in a group setting, there are things that can be shared in a milieu setting, but not everything needs to be shared to a certain degree with everyone. And family involvement is always critical. You know, I know that here at Crossroads, we have a period of time where when a client enters treatment, she can't make outside phone calls to her family, can't receive outside phone calls from family or friends. Our clinicians will begin doing that work right off the bat, but we like to give women some time to settle in to treatment. But when you are a mom and you have young children at home and they don't understand why mom is gone, you could have higher relapse rates if you do not support calls for moms, you know, calls to their young children. So it's important for the clinical team to look at what's going to be best for our mom and her children. And within that period, that first 5 days, you know, it's important for us to be supporting mom with calls to her children or Skyping with her children, because that connection and that bond is incredibly important to them. So we're focusing on increased periods of sobriety. Tobacco cessation is important around any level of care. But I emphasize this especially in the residential level of care, because what I never want to hear is that a woman increased her tobacco use while in treatment or started using tobacco again because because she was in treatment. And I say this because women will use substances as a means to connect. So take a look, if you're someone who operates a residential program, or you have a setting where, you know, maybe it's day programming and there are breaks built in, take a look at what's happening during those breaks and how people are joining together, and begin looking at, you know, is everybody going out for smoke breaks? Are people going out that are not smokers, exposing themselves to secondhand smoke, just so that way they can be a part of a group? Those are things that really need to be explored, and we need to offer treatment because tobacco is a substance. Self-esteem development is important in learning. Assertive and healthy communication skills and boundary setting, as I said earlier, are critical. And connection with a 12-step environment community is important, but with staff support. Women with trauma may have extreme difficulty looking at, you know, if I had someone in a residential program for 28, 30 days, and then part of their aftercare plan was to begin participating in the 12-step community, if this woman has never been to a meeting in her life, it might be very difficult for her to walk in to a setting of strangers, people that she doesn't know how to navigate the environment. So we do this in our programming with staff support. Oftentimes, the transition from residential, you know, if people have access to these services, if insurance covers it, if it's in their area. I know that there are some variables that can affect the continuum of care, but typically the step down from residential level is either a PHP, partial hospitalization program, or an IOP, intensive outpatient program. So again, increased period of sobriety is a goal of treatment. Women may be returning to work where they had previously taken some time off to attend residential. And they're also learning to remain abstinent from substances within their own home environment. So this might mean returning home, returning to work, returning home to children and work. And so they have to begin practicing early recovery skills in their natural environment. Continuing to set healthy boundaries with acquaintances at work, friends, family. Again, women are of this mindset sometimes that they need to be everything to everyone, and they do a lot of heavy lifting, and they'll sacrifice their needs on a consistent basis for the needs of other people. So it's important that we're constantly looking at this in an IOP, PHP level of care as women are adjusting to coming out of residential treatment. Women are managing temptation, stress, potential access to substances, and learning how to make room for recovery in their lives. And also learning how to connect with the 12-step community, the fellowship community on their own time. Sometimes here in our intensive outpatient, we will take women to 12-step meetings as an exposure activity of, you know, one, yes, we want you to increase your sober supports, and we want you to be familiar with groups in your area that you can go to receive support on your own time. But also there can be a lot of avoidance, because if there's a history of trauma, to walk into a group, to a 12-step meeting, that can be incredibly intimidating. So again, we want to increase the comfort level there. And sometimes an IOP or PHP could be a point of entry into a higher level of care. Sometimes clients may present at the residential level of care, at the ASAM criteria for residential level of care, but for whatever reason, they may decide to participate in a lower level. And if they can't maintain their sobriety, it's important to look at elevating that person up for additional support. Outpatient sometimes is often the first point of entrance into treatment. Clients may present at the OP level of care and very much need a higher level of care. Clients may demonstrate the severity of their substance use disorder, but may not have the financial means or insurance to move forward to a higher level of care. So there's a lot of case management work that we sometimes do, and collaborating with other outside organizations who are our community partners. And I encourage all of you to look at who are your community partners, who do you need to build into your team of professionals that you can utilize for support with your clients. And of course, in any setting and throughout the continuum, therapeutic rapport is critical. That relationship, if a woman doesn't feel safe, she's not going to continue with treatment. So throughout the continuum, we're evaluating relationships, decisions, and preferences. It's important to be mindful of cultural and societal influences in the lives of women and how this has shaped their value system. Activities are assessed and explored to identify any variables of alignment with their values and their interests. So what was of interest to a woman when she was active in her substance use disorder, it may not align with her value system now that she's had some sobriety under her belt. That may mean that she needs to set some strong limits with certain family members who may have, or coworkers, friends who may have expectations of her that are not realistic and not supportive of her current sobriety. Women are looking to understand who am I and distinguish aspects of their personalities that made sense in active addiction versus recovery. And I just think it's really important to note and to share that sometimes women who have entered our all women groups and programs, they initially say, I don't know how I'm going to make it here. I don't get along with other women. I get along better with men. My closest relationships are with men. And we have to challenge them on that because oftentimes their trauma has occurred with a man, but yet what they're saying is that they're more comfortable with men. So I always look at that as a little bit of a reflection of their own personal self-esteem and self-worth. And oftentimes what we see is someone's nearing the end of treatment. They've learned to develop healthy relationships with women again. They've learned to be able to speak positively about other women. And when I start seeing that, then I know that there has been some healing that's taken place within a client's sense of self and self-esteem. So it's all some special considerations for women is always domestic violence throughout the continuum of care. We have seen time and time again clients that have had difficulty accessing treatment because their partner has put up barriers that have resulted in them in their inability to attend treatment. So if you have a client, a female client who's frequently no-showing, try and look at that as a deeper lens. We don't necessarily want to jump to the conclusion that the client's not ready for treatment, that the client isn't being compliant with treatment. You know, I think that those beliefs can sometimes be disheartening, and you know, as providers, we have to look deeper and think about what's happening in this person's family, what's happening in this person's community, what could be going on in the relationship that's preventing her from being able to be consistent here in treatment. We've seen partners take the car right before a woman's appointment, even though the partner knew that the client had an appointment. We've seen people hide the keys. We've also seen women who have admitted to our residential level of care, and while locations are private, their partners is calling the center and trying to figure out, if their loved one is in treatment here. So you need to be everybody needs to be on board around what it means to be trauma informed and trauma responsive. And everybody across the board in your organization or in your group practice needs to be aware of what are the potential challenges that could result for a woman seeking treatment. How might their loved one try and coerce information, try and find out where they are. So everybody needs to be on board and have the support in place to know how to handle some of these situations. We invite our local partners in the community who specialize in domestic violence to come in and facilitate groups on a regular rotating basis in all of our residential programs and IOP programs, because it's important for women to understand what is out there for support for them if they're in a DV situation. And if they are not, it's really good for women to be empowered with this information, because then they can be aware of how they can support another woman who may be experiencing a DV relationship. So across the continuum, women are managing the various roles they have, as well as the relationships they are in as mother, daughter, sister, wife. They're trying to balance expectations, such as capacity within their relationships, and learning what it means to be a woman in recovery. So with that said, You know, I could spend a little bit more time talking about pregnancy, but I think that this might be a nice place to stop and take some questions, if there are any questions from any participants. Okay. Not seeing any questions yet, so I'm just going to try and see if I can exit this Q&A screen, and I'll return to that. We have about 10 minutes left of the presentation, so I'm going to try to share a little bit more about you around substance use and pregnancy, as this is a very challenging time for our clients when they are accessing treatment. So studying the effects of prenatal exposure of substances on fetal development isn't clear cut. Oftentimes when our clients are presenting to us, it isn't just one substance. So again, it's difficult to study what substance has what effect on the fetus. And there are multiple variables that can impact a baby's development: maternal nutrition, existing support system, use of other substances, and home environments. So at Crossroads, we have a residential program that's specific to women entering treatment with their children. It's our Children and Mothers residential program, and in this program, it's a 16-bed program. There are 5 beds that are reserved for women that are bringing their children ages 0 to 6 with them to treatment. And typically when women are coming in with their children, they can stay for about 60 days. We also accept women at any stage of their pregnancy in this program. So it's not uncommon to have a woman admit, and then maybe a few days later, she's in labor, she goes to the hospital, and she has her baby. Hopefully she's able to return to treatment with her child with her. Sometimes her baby may need some additional care in the hospital, and we really try to support visits with the baby while also balancing treatment for mom. So I just encourage you, if you're someone who is treating the female population, to look at any barriers that you can reduce. If you're facilitating an IOP, for example, and you have a mom who has a baby that's a few months old, is this an appropriate setting where mom can bring her baby so she can get some group treatment? We certainly allow that here and support that here at Crossroads. We want women to be able to be the moms that they've always wanted to be, and having access to treatment is incredibly is incredibly valuable and important. Not every woman who consumes alcohol during pregnancy will give birth to a child with a fetal alcohol syndrome disorder. Fetal alcohol spectrum disorder, sorry. However, because science has not determined a safe level of alcohol that may be consumed during pregnancy, the possibility of an FASD is created at any time a pregnant woman consumes alcohol while pregnant. I throw this in there because I have heard and from multiple women that they have been told, you know, at some point in their pregnancy, oh, if you have just one glass of alcohol, it's not going to hurt you. If you have just one, and you know, when our providers are sharing that with our pregnant moms, we don't know how that's going to be received, what's a little bit to one. So it's, you know, no use is really the ideal, but we understand that addiction doesn't discriminate. And that it's important to screen everyone for substance use disorder when they're coming in for prenatal care or coming into our setting for treatment. When treating the pregnant parenting population, it's important, you know, language is incredibly important. We want to refrain from language that states drug addicted babies. Babies are not born addicted, they're born exposed. Let me see if we have any questions currently. Let's see here. All right, okay. Will a replay be available? I missed the first half hour. Yes, a replay will be available. We believe C4 Recovery will be posting this on YouTube. How does having male staff impact the treatment milieu? I love this question. This is a great question. I think what's really important across all staffing, whether it's female, you know, if you have male and female staff, is that everyone's trained on what it means to provide gender responsive treatment for the population that you're serving. Here at Crossroads, our residential programs are specifically for women. So it's really important that people that are working in our programming understand what gender responsive treatment for women looks like, and that that's how the program is developed and created. So male staff is absolutely important, and oftentimes can provide a very corrective experience on what it means to, you know, how to be, you know, treated with respect. Sometimes our female clients that are walking through our doors haven't had positive experiences with men. So for women to come here and have a positive experience with another female is just as important as having a positive experience with another man. Okay, we have a few more minutes. I'm going to keep going here. Let's see, additional thoughts. So breastfeeding is encouraged at times while cautioned at others. So really having women consult with their doctor on this. Postpartum depression should always be assessed when you're treating clients. I recommend the Edinburgh Postnatal Depression Scale. It's 10 items. Typically assesses the past 7 days of functioning, but it's really important to rule that out when we're working with our female population, especially if they've had a baby recently. And we need to recognize the importance for opportunity for bonding and nurturing. You know, there's a lot of stigma that, oh, how can a mom have done that when she was driving with her car, and, you know, with her kids in the car? Or how could they do this? Don't their kids mean anything to them? Of course, their children mean something to them, and we want to create opportunities for the bonding and learning how to parent in a healthy way for our moms, especially if they never had that experience growing up. So involving families is incredibly important. I've alluded to that a little bit. And if a family member isn't safe because there's been a DV situation, asking women, well, who is your support person? Who can we bring in to support you in your recovery? I want to share some of the clinical programming that we offer here at Crossroads in our residential program to support our women. Seeking Safety by Lisa Najavitz, A Woman's Way Through the 12 Steps with Stephanie Covington, Helping Women Recover, which is Stephanie Covington, Healing Trauma, Stephanie Covington, Beyond Trauma, Stephanie Covington, Nurturing Parenting. I talked about the importance of bringing medical, whether it's nursing or a psychiatrist or a doc, to discuss the medical aspects of addiction and really supporting moms maybe that have been using during their pregnancy on what to expect potentially when their baby is born, and then the support systems that you're going to get in place and help them get in place and establish when they do give birth, because that can be a very stressful time for moms. Simply using a cognitive behavioral approach is too narrowly focused for women. Women's treatment needs to incorporate a holistic model of addiction, emphasizing effective cognitive and behavioral change. And that's directly from Stephanie Covington. So of course, our work as providers always is fostering a corrective experience, and especially in the lives of women, acknowledging the importance of healthy relationships and the role that we as treatment providers have in this. I'm just gonna scroll up to the top here, see if we have any more questions that have come up, and I'm not seeing any. So if you have any questions, this is a good time to get them in before we end today. All right, well, thank you very much for joining us. I'm not seeing any new questions pop up. After this webinar, you will, there will be a poll that I encourage everyone to answer and respond to. This will give us feedback, not only for me as a presenter, but C4 Recovery on how we can improve our processes. Really appreciate all of you participating today. And thank you very much to C4 Recovery for providing me with this opportunity.